Hi, welcome back. I'm Carmen Castañeda, and I will be the chair of the symposium called The Collaborative Work with Families, Redefining the New Frontiers in Family Interventions for Psychosis. You can see everyone here. During this time, if you have any comments or want to interact with other attendees, please use the chat function next to live stream. If you are using socials, don't forget to use the conference hashtag IEPA 2021 virtual. If you wish to ask a question to a speaker, please use the Ask a Question button under the live stream. Send your questions in at any time throughout the presentations, and they will be addressed at the end of the sessions in the live Q&A. This symposium will highlight the value of the work that can be achieved through collaboration between families of individuals who have experienced psychotic episodes and professional teams working in psychosis intervention services, emphasizing the importance of family involvement from early stages to accomplish a better recovery. We will see how in different countries, family interventions are focusing on fortifying the carer role of the family, providing the necessary tools to play to their strengths, bringing out their potential, and also recognizing their valuable contribution as providers of feedback about the interventions improvement we can act on. Now, I'd like to introduce our first symposium presenters, Sarah Kopelovich and Bryan Stiles. Dr. Sarah Kopelovich is a forensically trained licensed clinical psychologist in the Department of Psychiatry and Behavioral Science at the University of Washington School of Medicine. She's an assistant professor at the University of Washington and holds a professorship in cognitive behavioral therapy for psychosis. Her research is focused on training, implementation, and dissemination strategies for evidence-based psychotherapeutic interventions for individuals experiencing early and persistent psychosis. She has served as the principal investigator and co-investigator on several projects with the NIMH, SAMHSA, and the Washington State Healthcare Authority. She oversees several psychosis-related clinics, such as the CBT extensions for community healthcare outcomes clinics. And she also leads the implementation effort for Psychosis Reach, a CBT for Psychosis-Informed caregiving training for community members. Bryan Stiles is a graduate student in the clinical psychology program at the University of North Carolina at Chapel Hill, under the mentorship of David Penn. His current research is focused on the development and implementation of psychosocial interventions for individuals with psychotic spectrum disorders, particularly young adults experiencing first episode of psychosis. He previously worked with Dr. Sarah Kopelovich at the University of Washington, where he assisted with the implementation of Washington State's early intervention program for a first episode psychosis called New Journeys, the establishment of Washington State Echo Clinic, and rollout of Psychosis Reach. Please welcome Sarah and Bryan with their talk, Reaching Families Sooner, Responses to CBT for Psychosis-Informed Training among Families Experiencing Early versus Persistent Psychosis.
Thank you for joining us. I'm so privileged to be presenting here today, and I want to express my gratitude to the IEPA organizers for making this virtual conference happen, and to all of the support staff as well. I am Sarah Kopelovich. I'm an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington, which is located in the beautiful Pacific Northwest of the US. And I am joined here today by Bryan Stiles, who's a doctoral student in the Department of Psychology and Neuroscience at University of North Carolina at Chapel Hill. We are going to be presenting on behalf of our co-authorship team, which includes our colleagues, Dr. Maria Monroe DeVita, Dr. Kate Hardy, and Dr. Douglas Turkington. And we're presenting on a training called Psychosis Reach, which I'm pleased to be talking to you about. And we'll be looking at differential responses to this intervention between families experiencing early versus persistent psychosis. Before I begin, I have to note that although Bryan and I are taking the lead on this presentation, that we have had the good fortune of working with an incredible team, both at the University of Washington, which includes Maria Monroe DeVita, Dr. Kancha Vaswani-Bai, and Jennifer Blank, a research coordinator, as well as our colleagues, Kate Hardy, Doug Turkington, and then our phenomenal cohort of Psychosis Reach family ambassadors here in Washington State, which you see in that upper corner Zoom capture. I also want to acknowledge my funders for this work. We've been fortunate to be in the position of receiving generous contributions from benefactors who are invested in innovations that focus on the support system of individuals experiencing serious mental health challenges. And these individuals have invested in me through the professorship in cognitive behavioral therapy for psychosis, as well as the Family and Caregiver Fund to really advance this work. So I am going to be sharing with you a now 2.5-year-old training program that's currently being scaled up internationally. And it's called Psychosis Reach, which stands for Recovery by Enabling Adult Carers at Home. So my ambition in the limited time that we have to talk about this program is to present some of the evidence supporting training for families who are navigating psychosis, to present our model of training and its components, to look at our training outcomes among families experiencing early psychosis and those experiencing persistent psychosis, and then to highlight recent adaptations that we've made and future directions we're taking this based on our observations. And if you're interested in learning about some of our global findings from this initial cohort that we'll be talking about today, Psychiatric Services just a couple of months ago published that paper, which is seen here. Okay, so let's dive in, and I'm hoping there won't be too much overlap with what my colleagues on this symposium are presenting in terms of the evidence-based supporting family involvement in psychosis treatment and the hazards of what has become the status quo in the US, which is lack of involvement and even in some cases to the point of familial neglect. So it is the case that while we have seen rapid scale up of early psychosis specialty care programs across the United States, that many Americans with a serious mental illness are still unable to access mental health care and are rarely accessing evidence-based care. And we know that rates of access is substantially poorer among people of color with a serious mental illness, with recent estimates suggesting that only 11% of Latino Americans and 13% of Black Americans are accessing mental health care. And thanks to our colleague at the Washington State Center of Excellence, Dr. Duni Oluoye, we know that those trends persist even among our more recently implemented first episode psychosis coordinated specialty care teams in the US. Among those who do access treatment, we're seeing very poor rates of access to sort of what are considered our gold standard psychosocial interventions. So a point prevalence estimate that I recently conducted suggests that fewer than 1% of Americans receive access to cognitive behavioral therapy for psychotic symptoms. And thanks to a report that was produced a couple of years ago by the Interdepartmental Serious Mental Illness Coordinating Committee, we know that unfortunately fewer than 1% of our families are receiving a family intervention for psychosis. And it's really important for us to be keeping this in mind for two reasons. One is that we have good data that suggests that both of these interventions are not just helpful in producing positive treatment gains, but that in some cases, the effect sizes for these interventions, in many cases, are comparable to psychopharmacologic trials for individuals with schizophrenia. And that was produced in a recent systematic review with the Agency for Research Health Quality in 2017. So I think it's really important for us as clinicians, as researchers, as peer specialists, as family members, as individuals with lived experience, that when we're reviewing some of the literature looking at longitudinal outcomes, that we bear in mind this context of poor access to treatment, which have really demonstrated efficacy in the literature, that's having a huge impact on the outcomes we're seeing at the population level. And the true standard of care is in conflict with what our national psychosis treatment guidelines recommend as standard of care, both in the US and abroad. And so these guidelines were just updated in 2020. They're based on the AHRQ systematic review. And in these updated guidelines, they reiterate the call for evidence-based therapies, and they talk about these psychosocial interventions as the mainstay. So this is from the Family Companion Guide to the practitioner guidelines that state that medications are a complement to psychosocial treatment and are equally important part of the overall care process. So it's not just the case that individuals with psychosis and their families are not receiving evidence-based psychosocial interventions. In fact, the situation is even worse. Despite the fact that a majority of adults who experience psychosis live with a family member and familial involvement is often requested, most mental health providers report having had no contact with the families of their patients. And what we see then is this scenario worldwide in which caregivers are providing more support, more contact hours than the mental health system, but are receiving little to no support or training themselves. And of course, from an outcomes perspective, this approach is counterproductive, because the evidence base extolling the benefits of family involvement in their loved one's care has been reviewed extensively. When support is extended to family members, relapse rates have been shown to be reduced by as much as 40%. And a Cochrane review of studies conducted worldwide confirms that family interventions for psychosis can not just reduce levels of relapse, but hospital admissions, expressed emotion, and lead to measurable improvements in social functioning and treatment engagement. So it's not for lack of knowledge that we see this science to practice gap, and it's not for lack of motivation, but what we see is a failure for family interventions for psychosis to take root in clinical settings in the US to date. And so Psychosis Reach essentially aims to do two things. One is to circumvent the supply chain issues related to delivering these interventions by taking the family intervention out of the clinic and bringing it directly to the support network. And then the second is to combine the schizophrenia treatment recommendations for providing high-yield cognitive behavioral techniques, psychoeducation, and family interventions to family members. And I want to clarify that the idea here is not that we are tasking family members with delivering CBT for psychosis, but rather that we're helping them engage in more therapeutic interactions with their loved ones that can lead to more skillful communication and skills practice potentially, but that essentially wherever this loved one is presenting, that the interactions with others become therapeutic interactions and really maintain that recovery orientation. So let me describe the Psychosis Reach training model, and I'll give the 30,000-foot view here. Psychosis Reach consists of 3 primary components, each of which is built on foundational principles and techniques that are found within CBT for psychosis, developed by Dr. Turkington, one of the progenitors of CBTP, Dr. Hardy, myself, and Dr. Monroe DeVita. So the first consists of recovery-oriented psychoeducation. And we know that psychoeducation is recommended even as a standalone intervention. We help families make sense of what they're observing, what they might expect. We separate facts from fictions, do a lot of anti-stigma work. And We also share the latest research with families in an effort to ground their hope in empiricism. We share with them a culturally informed cognitive behavioral model for understanding psychotic and psychotic-like experiences. And that includes educating families as well about what our national psychosis treatment guidelines prescribe as standard of care, so that our families then can become informed consumers and consumer advocates. The next is caregiver self-care. And here we really are talking about the application of cognitive behavioral theory and therapy, not just to psychosis, but to the caregiver experience. And we emphasize that CBT is a form of self-care, and coupled with some of the more traditional forms of self-care, exercise and yoga and diet, that those forms are all of those work together to help them, and that they then can become a more present and more patient caregiver and family member. And then finally, we coach them in CBT for Psychosis-Informed skills and concepts, using an acronym to help them remember these skills called FIRST, the FIRST skills. And here we're teaching family members these key skills to support their loved ones who are experiencing psychosis. And these are skills that we have selected so that they can be executed without going and getting a clinical degree, right? So the idea here is that these can be used off the shelf. That doesn't mean that they're going to be executed, perfectly every time, or that they don't need some support to help with the application. And Bryan and I will be talking more about what that looks like later. We also clarify roles and boundaries, right? So we clarify the fact that we are not putting family members in a position where they're administering therapy. We're not intending to replace treatment. This is really, if you think about teaching parents how to check blood sugars and operate an insulin pump, that they are working alongside and in a complementary way to the care team. And we really seek to empower family members with information and skills to create a space for them to come together with other families for connection and co-learning as they are learning these skills really together in a community. So the first skills are broken down here on this slide. We think of FIRST both as a mnemonic and also as a way of communicating to family members to try these skills first from now on, to really start to replace some of the patterns of communication that have formed over many, many years, and to really try these first now. And the skills build on one another, but they can also be used in an iterative way, right? So if the relationship ever feels like it's getting rocky, things are getting contentious, we guide the families to go back to that F skill, fall back on the relationship, activate positive memories, build on those strengths and shared goals. Okay, so we're going to go through what we did and how we approached the training, and then Bryan's going to share what we found. So I think what's important to know for the purposes of this presentation, we're focusing on our first cohort of trainees. We've now trained 4 cohorts of trainees and have 4 trainings projected through 2022. For this first one, this was pre-COVID. We were an 8-hour in-person workshop, which included didactics, empathy building exercises, and skill demonstrations with a lot of opportunities for discussion and Q&A and interaction. What's important to know about our approach to this initial cohort is that we were pulling from the Northwest, where University of Washington is situated, and targeting agencies that were already delivering CBT for psychosis and first episode psychosis programs that my team at University of Washington has trained, as well as regional affiliates with the National Alliance on Mental Illness. So not a random sample, and I'll talk more about that later. So I'm going to shift things over to Bryan now, and he's going to walk us through our findings.
Thanks, Sarah. So in this first cohort, we had 168 caregivers consent to participate, and online surveys that we administered prior to, immediately following, and 4 months following the training. And as you can see here in this matrix, we gathered caregivers' demographics and their loved ones' clinical characteristics, as well as a series of outcome measures, which I will review in detail in the coming slides. As we can see here, a majority of our training sample, and we can go ahead and highlight on the slide, was represented by white, married, well-educated women who identified most often as mothers in their caregiving role. To look at between caregiver differences, what we did is we split our sample based on the caregiver's report of their approximate time since the loved one first received a diagnosis. And we then operationalized early psychosis as caregivers with loved ones who had fewer than 5 years since the onset of their symptoms, and persistent or multi-episode as greater than 5 years. And when we compared these groups using Fisher's exact text, we observed that both groups were demographically like one another. For those of you who are unfamiliar with the Pacific Northwest region and the state of Washington in particular, the western half of the state carries the majority, about like 78% of the state's population. And so when we set out to see where our trainees were coming from, perhaps not surprisingly, we found that our trainees were concentrated in this kind of major urban corridor of the Seattle-Tacoma metro area, with a minority representing more rural areas of the state. And as I mentioned a moment ago, trainees were typically a parent figure, with about 76% attending on behalf of a child. And a little over 2/3 of caregivers reported that their loved one's diagnosis fell within the schizophrenia spectrum, with a sizable amount reporting diagnoses of mood disorders. And across our entire sample, loved ones carried their diagnosis approximately 5 to 6 years by the time of the training. And as you can see, lifetime hospitalizations varied widely. So when we used Mann-Whitney tests, we found significant differences on these variables between early and persistent psychosis caregivers, which was an expected finding driven by our operationalization of these two groups. Turning to our outcome measures, we used the experience of caregiving inventory to measure subjective positive and negative caregiving experiences. And just to orient you, higher scores on this measure represent higher levels of negative or positive caregiving appraisals, depending on the dimension viewed. Prior to attending the training, we saw that trainees were reporting pronounced caregiving associated burden over multiple dimensions. So issues such as those brought on by the difficult behaviors of their loved ones, negative symptoms, the need for backup, and or the dependency of the loved one, to name a few. And when we followed up with families 4 months after the training, we found that all of these negative dimensions had decreased significantly. And in considering group differences across these scales, we conducted a series of independent t-tests, or when indicated Mann-Whitney tests, at follow-up only. And we found that each test didn't reach statistical significance, suggesting that persistent and early psychosis caregivers had comparable mean scores across all dimensions of the ECI at the end of the study period. And then turning to our mixed ANOVAs, where we evaluated between group differences over time, we did find a significant interaction effect on this particular scale, the ECI backup scale. So as you can see, the simple main effect of group here was not significantly different at each individual time point, but we did note that early psychosis caregivers had a different overall trajectory of improvement. So again, in this figure, over time and relative to persistent psychosis counterparts, early psychosis caregivers reported less preoccupation with providing financial support or making accommodations for their loved one. We also evaluated attitudes towards psychosis, and we did this with the Psychosis Attitude Scale, which was a measure originally developed for clinicians training in cognitive behavioral therapy for psychosis. And we adapted this for the caregivers in our training context. And this measure yields total score, with higher scores representing more prosocial views or attitudes towards individuals with psychosis. Overall, all trainees from beginning to end of our survey period demonstrated an improved trajectory of prosocial attitudes. When we ran mixed ANOVAs to evaluate change in attitudes over time between these groups of caregivers that I talked about, early and persistent psychosis, we saw no interaction effect. However, we did observe that there was a significant main effective group such that averaged across all of our time points, early psychosis families reported lower prosocial attitudes. And this is about a mean difference of 6 points on the psychosis attitude scale. We also looked at self-reported depression and anxiety among caregivers with the Hospital Anxiety and Depression Scale, or HADS abbreviated. And here, higher scores indicate greater levels of anxiety or depression. And so with the entire sample, we saw statistically significant reductions in anxiety and depression before and immediately following the training, as well as significant reduction overall from pre-training to follow-up. And it is worth noting on this slide that our sample never fell within the HADS defined limits of borderline abnormal or abnormal depression, and that anxiety did remain within the limits of the borderline abnormal category, although it did come close to normal ranges. In our mixed ANOVAs, we did see that early psychosis families reported significantly greater anxiety concerns at pre-training compared to persistent psychosis caregivers. Although the mean anxiety scores were comparable between groups at subsequent occasions. However, early psychosis caregivers demonstrated a significant and sustained reduction in anxiety symptoms over time, whereas in comparison, persistent psychosis families didn't significantly differ in their reported anxiety at the end of the study relative to their standing at pre-training. In terms of depression, the reductions at each adjacent time point for early psychosis families, in other words, the pre to post and post to follow-up, were not statistically significant reductions, but again, that overall trajectory that we're seeing here suggested a gradual and sustained decline in depression-related concerns among early psychosis caregivers. And again, in contrast, the trajectory of depression symptoms for persistent psychosis families was not significant. And actually the little uptick from post to follow-up was evidence of a significant increase in HADS-rated depression scores. We also looked at expressed emotions. So this is that level of criticism, hostility, emotional over-involvement in the home environment. And on this particular measure, the family attitude scale, we see that higher scores indicate higher levels of burden or criticism. And we found that overall, after receiving the one-day training, all caregivers reported less expressed emotion, and that this was a change sustained 4 months later. But when we differentiated between early and persistent psychosis caregivers, there was no interaction effect, but a main effect of time, meaning that the improvements in expressed emotion from one occasion to the next average across our groups was significant. And that was about a pre to follow-up reduction of about 8 points. And finally, we asked caregivers to rate their perceived mastery of CBTP-informed skills as taught during the REACH training. And higher scores here indicate kind of greater confidence, expertise in using the skill. And as we saw here, and illustrated on the slide, family and caregivers self-reported higher scores immediately following the training across all dimensions of the first skills. Despite seeing some attrition in skills mastery in the 4-month period following the training for 2 of our dimensions that we rated here, the overall picture was one of increased and sustained sense of mastery over the CBTP-informed skills taught in REACH. In general, early and persistent psychosis caregivers benefited equally in terms of these skills. And although we noted interaction, did not note interaction effects between group and time on any of these skills, we did see that early psychosis families rated themselves lower, averaged across occasions on the reviewing the information skills. So early psychosis families felt less confident about their skill in walking through a formulation of their loved one's psychosis or their symptoms.
Great, thank you. So I really want to note and reiterate the point that these data represent a real world implementation of a training program for lay family members in the community, that because this was not an RCT, our trainees self-selected to participate in the training. We didn't have access to a matched control group. We relied on within group analyses for our total sample of trainees and post hoc analyses of our early versus persistent psychosis family members. So these results really need to be looked at in a more controlled fashion. That's really one of our next crucial steps is establishing an RCT. And I want to also key in on the fact that our trainees were fairly homogeneous on key demographic, geographic, and relational variables. Right, as Bryan discussed, our sample was comprised disproportionately of white mothers with at least a 4-year college degree. Most were already connected to care and to family advocacy organizations based on where we sampled. So what have we learned? What are some of the key points? So overall, our sample did report improvements on aspects of caregiving from pre-training to follow-up, and both of our persistent and early psychosis samples seem to benefit equally on this measure. But we did observe a modest but statistically significant improvement in the early psychosis group report of the backup support they have, and I want to come back to that in just a moment. Another key point is that this was a 1-day, 8-hour training, and yet we were able to pick up on some changes in the way that families view psychosis, its understandability, and its treatability. And interestingly, our early psychosis families reported more stigmatizing views of psychosis than our persistent psychosis families, but both groups reported similarly improved attitudes at our no contact follow-up point. And given the importance that beliefs and expectations have been found to play in one's recovery journey, this strikes us as an important intervention or an important intervention point. We did overall find, we did see as a whole that our sample was mostly reporting subthreshold symptoms of an anxiety or depressive disorder, but our early psychosis families reported higher levels of anxiety before the training. All families reported that reduction in these symptoms that was sustained at follow-up. Given the importance that expressed emotion has played in our understanding of risk of relapse, we wanted to evaluate this construct in our sample for both of our groups. We didn't observe significant differences in EE between these groups, and overall their self-reported expressed emotion was significantly reduced after the training and sustained at follow-up. And again, I think this was particularly impressive to us in light of just what a light touch intervention this was, small sample, restricted range. So this is something that we really want to follow up on. Our findings on the ECI in particular really spurred some hypothesis generating. So specifically the finding that the early psychosis families suggested, had some kind of more support at follow-up. Perhaps family members who are within the first 5 years of a diagnosis benefit, don't have that community, right? They might be engaging in isolation and secrecy, and due to some of that, those stigma messages that they're reporting at pre-training. And so it's possible that the connection and the destigmatization that occurred during the training empowered them to seek support from their own communities subsequent to the training. By and large, we found comparable response to queries of their self-perceived mastery of the first skills across both the groups. What our data indicates is that people need that follow-along support, and that makes sense, right? That data mirrors what we know to be true of training health professionals, right? Training without longitudinal skills practice, which includes preferably feedback, is not sufficient for a practice change. So these findings really generated important adaptations to the training model that have been subsequently implemented. And the first is the incorporation of family peer trainers to help sustain and scale psychosis reach. We have a training manual for new Psychosis Reach family ambassadors, and they serve both as co-trainers during the live event, as well as coaching support for families subsequent to. We also made a shift to hybrid synchronous and asynchronous training administration. It was prompted by the pandemic, but it was really carefully designed to preserve that connection that our trainees form with one another. And then our third change is to enhance accessibility and reach, is ensuring that all of our materials are appropriate for monolingual Spanish speakers. So we are in the process of scaling Psychosis Reach up both domestically in the US as well as internationally, working with colleagues in Pakistan, the United Kingdom, Canada. And then I've also just been funded to develop a artificial intelligence-based model of Psychosis Reach skills training that relies on machine learning and natural language processing. And that was funded by the University of Washington Garvey Institute for Brain Health Solutions. So I just want to direct you to a few resources. There's a book chapter forthcoming that fleshes out some of these skills and how they can be woven into clinical practice. Dr. Turkington and Dr. Spencer wrote a book, Back to Life, Back to Normality, which is really sort of a first version of what we now call Psychosis Reach. And then psychosisreach.org, we have a lot more information about future trainings and research efforts. So I encourage you to reach out to us or connect to us through our website. Thank you so much.
Thank you, Sarah and Bryan, for this wonderful talk. Now to the audience, please don't forget to send your questions. They will be addressed at the end of the session in the live Q&A. Now I will introduce myself since I am the next presenter. I am a clinical psychologist who has been working the last 13 years in the early intervention in psychosis program pro-ITP at the Dr. Jose Horvitz Barak Psychiatric Institute in Santiago, Chile. Now I'm working remotely. Throughout this period, I have specialized in psychotherapy and psychoeducational interventions for young people presenting first episodes of psychosis and their families. My research has been focused on cognitive, psychological, and physical health aspects of psychosis. I have participated and also conducted national conferences promoting early intervention in psychosis. And currently, I am the director of psychological interventions for early psychosis diploma at Diego Portales University in Santiago, Chile. I am also a member of the Latin American Network for Study of Early Psychosis called ANDES. This talk is called Hear from the Experts, the key role of family members and caregivers of young people experiencing a first episode of psychosis in the improvement of a multifamily psychoeducation intervention.
Hello, everyone. My name is Carmen Castañeda. I am a clinical psychologist from the Early Intervention in Psychosis program pro-ITP from Chile. And I have prepared this presentation titled, Listening to the Experts, the key role of family members of individuals experiencing a first episode of psychosis in the improvement of a multifamily psychoeducation intervention. First, I would like you to think about this question. Why work with families? In Chile, as in many other countries, young people experiencing a first episode of psychosis are living with their families while the onset of first symptoms, and they will continue living with them once they are discharged from the hospital if they have been hospitalized. Additionally, no one else knows their kids more than the family. Their information about pre-functioning status, previous personality, and goals for the future are invaluable tools to work with through the remission and recovery process. Culture plays a very important role in families' approach to illness, treatment, and support, especially in the Latin community. It's very common that children leave their parents' house in their late 20s or early 30s when they get married. In Chile, family bonds are particularly strong. This gets in the way of young people developing their independence and autonomy. This could be difficult, but it plays as an advantage for people experiencing mental health problems, as in most cases, families will tend to provide protection, housing, and access to work. Since families are fundamental in supporting and continuing the health care that young people have received at inpatient and outpatient units, we think about them as expert collaborators. Even though there is a recognition about the importance of family psychoeducation interventions for caregivers' well-being and service users' stabilization, little is known about the contribution of its participants to enrich psychoeducation through the assessment of these interventions. That is what we mean to present here, how their valuable feedback has improved over the years our multifamily psychoeducation intervention, benefiting hundreds of families during these past 16 years and have helped us to work collaboratively and grow as an early intervention in psychosis team. Now, I will walk you through the agenda of our presentation. First, I will talk about our early intervention in psychosis program and the Chilean guideline for schizophrenia, where multi-family psychoeducation is included as an evidence-based intervention. I will talk about how our psychoeducation works, what families have suggested for its improvement, and finally, I will share with you current and future challenges presented to keep those improvements. Our early intervention psychosis program, here we are. It's called PRO-ITP in Spanish. The early intervention in psychosis program is a mental health program for young people between 18 and 24 years old who have experienced a first episode of psychosis. We provide inpatient and outpatient mental health care at the Dr. Jose Horvitz Barak Psychiatric Institute, which is part of the National Public System. Our catchment area is the North Metropolitan Health Service Network in Santiago, the capital of Chile, but we also treat at the inpatient unit service users from other regions of the country. Our ward was created in 2005 with the main goal to have a specific place for young people who need to be hospitalized for the first time with schizophrenia spectrum symptoms and provide them a more outside-like environment, avoiding the impact of being around long-term clients. You can see a picture of our guard on the left. In the inpatient unit, we have 20 beds, 14 for males and 6 for female. And there are 100 clients per year receiving ambulatory health care. You can see most of the inpatient and outpatient team and on the picture on the right. The Chilean guideline for first episode of psychosis and schizophrenia has its first edition released by the Chilean Health Ministry in 2005. One of the main participants was the chief of the inpatient unit, Ruben Nachar, which has made us all very proud. And he has been involved in its 3 editions. The guideline aims to reduce medical and social complications associated to the schizophrenia diagnosis through timely, continuous, and effective evidence-based treatment. Also, to promote the early detection and treatment of schizophrenia. There is a law that guarantees the access to the interventions that the guideline has established as a quality standard of care for people presenting psychosis. The guideline also specified that family psychoeducation should be provided, but it was not until 2017 that procedure has been specified on how to provide it. It also says that it should be provided in all the stages of the illness and should involve families and individuals experiencing psychosis. The intervention should consist in providing information about diagnosis, symptoms, treatment, civil rights, coping skills, and prognosis in psychosis. The overall premise of the guide is that by providing users and their families with quality information, they are empowered to have an opinion and participate in decisions related to their treatment. Now I'm going to present you how we have been conducting the multifamily psychoeducation intervention. This intervention was one of the first interventions we conducted, and it was run from the very beginning of our work by the psychosocial team, a nurse, a psychologist, a social worker, and a occupational therapist, with a psychiatrist that was doing their internship. Families are invited from the very beginning to participate after the first contact with the team. We started intervention with 8 different topics and have been modifying it and increasing its scope based on new medical evidence and requests from participants. The intervention follows a comprehensive model, which includes education, support, and skills training. Sessions are open to new families, and they can complete all sessions even after their relative has been discharged from the ward. This helps families to feel support during the subacute phase when their relative is back home. Also, flexible cycles access has helped to share diverse experience from different stages of the illness, giving a hopeful view to families going through an acute phase. There are 3 cycles per year. The summer break is used to review the intervention and update the material according to the family's suggestions. Although we have been able to gather qualitative data, we're still struggling to evaluate experience with a more specific instrument, especially with families that won't continue their treatment with us. Since the pandemic, March 2020, our ward has been closed and transformed into a COVID inpatient unit. Young people presenting psychosis have been transferred to the adult guards along with our staff. Fortunately, we have been able to continue the family psychoeducation for those families through an online mode. So even without our guard, even if the guard is closed, we are still working together. The picture above shows the 2009 inpatient team, and the other below it shows the occupational therapist during her session. We have created a model that relies on 3 pillars: scientific evidence, our clinical experience, and families' feedback. Our clinical experience working with young people and their families has helped us to share our findings and teach it to students and new members of the staff in order to get everyone involved. We have also based our work in different manuals. For example, Origin's resource for family work called In This Together and IEPA's Healthy Active Lives model have helped us update certain contents. We work with the stress vulnerability model and also with the phases of psychosis model as frameworks, and also, of course, the Chilean guideline for psychosis. The systematic expansion of coverage has been possible through the inclusion of families of young people experiencing any kind of psychosis and during any stage of the illness. And now, during the pandemic, we have increased our scope and included families with their relatives hospitalized in adults inpatient units. Psychoeducation took a major step in 2017 when our model was added to the National Guideline for Psychosis. Since then, our intervention has been a national reference for teams from other hospitals and organizations. Several healthcare professionals have joined our sessions in order to learn from it, adapt, and replicate intervention in their own settings. As you can see, the sessions are organized according to hospitalization evolution and also considering the different stages of illness, from acute to remission and recovery stages. We hold one session per week. From 2005, at the end of each cycle, we have conducted a session exclusively to hear what families have to say about intervention. Since 2017, we have asked them to evaluate each session. With their written consent, we have been able to transcribe, analyze, and work with their ideas and suggestions to improve the next cycle. We have created a virtuous feedback cycle that benefits current and future families and service users. Recently, we conducted a group interview with some of the families that have been involved in all the online cycles to hear what we can do better and also understand the impact they think the intervention have had on them. This is very important because this is the first time that we have conducted online sessions. And since the results and the reach of the sessions have been positive, we are considering keeping online intervention even after the guard reopens. Now, the third pillar that I want to talk about more broadly is what families have to say to us. We have mostly have used their feedback and suggestions to improve the following cycle. Some of this process has been published in the Mental Health National Magazine in 2018. Online interventions data has been recently presented in our latest conference about early intervention in psychosis. Now we have organized the content analyzed in 5 categories, according to the suggested improvements, how the family have felt while participating on the intervention, and the perceived benefits after completing the psychoeducation intervention. The 5 categories are new educational needs, development of new shareable content, collaborative relationships between family members and service team, cognitive and emotional impact of the intervention on families and caregivers, and incorporation of the service users to the multifamily psychoeducation sessions. I am going to talk about 3 of them with more details. In regards to the new educational needs, families have suggested to add sessions that could help them preventing drug misuse in their relatives, how to care of their own mental health, sorry about that, and a session that could help them to recognize the differences between normal adolescent behavior and psychotic symptoms. Recently, we have also been asked to talk about the update of civil rights related to individuals with mental health issues, such as labor inclusion laws, which bring new opportunities to work in more inclusive settings. Finally, we have been asked to talk more broadly about suicide prevention, about the development of new shareable content. At the beginning, the intervention was mainly a multifamily educational talk with different content each session. Attendants used to bring a notebook and write as fast as they could all the information that was presented to them orally. In that time, the most valuable feedback that we received was related to the difficulties they were experiencing remembering everything that we were saying and staying on the subject. They suggested us to present as we were in class. So we incorporate PowerPoint presentations to the upcoming cycles. Next was the suggestion of a summary that they could bring home and share with the rest of the family. Since then, we have produced brochures for each section and also reserved some time of Q&As to address any questions from relatives that couldn't attend but had read the brochure. As requested by participants, we have been working on uploading and making the session material available on our website. We have also extended the time from 1 hour to 1 hour and a half, following family suggestions. The incorporation of service users into the intervention constituted a challenge for an acute inpatient unit and should be the next big step for the intervention team. Families want their relatives to receive the same information that they have. especially related to drug misuse and antipsychotic adherence. They believe that the possibility of sharing experiences with other service users will help them earn their trust, especially in terms of recommendation to feel better. So besides what we need to improve, families have also mentioned what has been valuable for them. We can see these benefits in the following 8 points. I'm gonna read them through. The importance of sharing their experience with other families living through similar fears and emotion and getting to know others' families' coping techniques. Perception of a stronger working alliance through a collaborative relationship with a mental health team. Emotional support for family members during the acute phase of the illness. Timely and accurate information related to psychosis. The feeling of empowerment to handle future relapses after users discharge by knowing how to detect early signs and symptoms in the event of a second episode of psychosis. Recognition of the role of the families as an effective support network for adherence and maintenance of the treatment and also for recovery. Learning good practices in home management and progressive incorporation into daily activities, and an attitude of greater hope to face the future. Getting to know the family's opinions about our work has brought benefits for all. Participation in psychoeducation empowers families in their caregiver role. On the other hand, their role in their intervention has made it possible to transition from an expositive intervention model to a participative one. Finally, suggestions and feedback from family members have led to a continuous review of our daily practice and the incorporation of improvements to focus the interventions on their specific needs. Now, I'm going to talk a little bit about the challenges. As mentioned before, since the pandemic started, our inpatient unit was transformed into COVID unit. Our service users were transferred to different units within the hospital, leaving the team with no physical place to conduct our interventions. Even though this presented huge challenges for us, we were determined to continue psychoeducation interventions, and it was clear that from a user's perspective, it was needed more than ever. And it represented an opportunity for the team to establish a place of collaboration, even when this place was not physical. There was also an increasing need from families to get involved with their relatives' treatment as much as they could, since the quarantines prevented them to keep in touch with their relatives when hospitalized. On the other hand, families from the outpatient unit were spending more time with their relatives at home and wanted to get support and orientation on how to handle diverse issues that come with the habit changes due to COVID-19. For example, how to manage users' isolation and subacute symptoms at home in order to prevent an hospitalization during this health crisis. Access to internet and ability to use online platforms were challenges for some parents. Fortunately, our service users, generally more tech-savvy than their parents, came to the rescue, helping them to connect and even sending occasional greetings to the intervention team. These greetings started to become more frequent and evolved into them staying throughout the session. In other words, the online intervention mode during the pandemic has opened new ways for outpatient users to get involved in the intervention by listening to the conversation or watching the slides while they have their cameras off. Some of them have even been writing questions on the platform chat as well. Also, the change in their role from patients to technology experts has empowered them to be part of their treatment by helping their parents to be connected to the intervention and learn more about their illness. The biggest challenge for the team was to adapt both the content and the way we used to organize each session in a short period of time. We added more sessions, made them longer, and followed the premise: more dialogue, less PowerPoint. During these difficult times, the intervention has been a way to connect to each other for everyone involved. The benefits outweigh the costs. Finally, we have been able to get our clients involved in the intervention, and we have also had more members of the same family participating. This is important because the caregiver role has been shared with others, making the associated burden more tolerable. We think that the possible next steps for our team are: include users more formally to the multifamily intervention, maybe conduct a psychoeducational intervention only for users, continue the online intervention when the world reopens, or maybe write a manual as a resource for others' first episode in psychosis teams. Finally, I would like to thank all the professionals involved in making this possible, and especially to the service users and their families. I hope you enjoyed this presentation, and thank you for listening.
Okay. Moving on, our final presenter is David Shires. David has been campaigning for mental health care reform since the late 90s, when his daughter was given a diagnosis of schizophrenia in her late teens. Derived from what he felt was lacking in his daughter's early experiences of care, David changed his career, leaving general practice to co-lead with Professor Joe Smith the United Kingdom's National Early Intervention in Psychosis program through the era of the National Service Framework. Now, sort of retired, David continues to challenge why people like his daughter should accept poor physical health. He co-led with Dr. Jackie Curtis the Healthy Active Lives, an international consensus of intervening early to protect people's bodies as well as minds, launched at the IEPA in Tokyo in 2014. He has taken part in several relevant NICE guidelines and quality standards, and was a clinical advisor to national audits of schizophrenia. Please welcome David on an interview where he will talk about demanding caregivers, the importance of physical health advocacy in mental health, why early intervention services should incorporate caregivers' perspectives to improve their family members' well-being.
Hello, everyone. I'm Carmen. I'm a clinical psychologist who works with young people experiencing first episodes of psychosis, and I will be interviewing David Shires today. I am very grateful to David because he kindly accepted to participate on our symposia as a caregiver and also as a physical and mental health advocate. He came up with this wonderful idea of interviewing. So David, thanks for being willing to share your experience. Could we start with you introducing yourself and share a little bit about your experience as a carer?
Okay, thanks, Carmen. Well, it's actually my privilege to be here. I've got sort of various hats, like we all have. So I have a professional hat, and I've got a family hat relevant to this. Now, the professional hat's getting a little bit grey and dusty. I qualified in medicine in 1974. Then I became a GP in a little town called Leek in the middle of England. And then I got involved in mental health reform after my daughter became unwell. So I was a joint lead with Joe Smith on the Early Intervention in Psychosis development program, which went from about 2002 to 2010 in England. I was then sort of retired and still felt some unfinished business in terms of physical health, which I'll come back to in our presentation today. But I've then got seduced by Toni Morrison to join the Psychosis Research Unit in an honorary research capacity, which was really quite a brave attempt by Toni to try and bring me in and make good use of my experiences. So that's my professional side. My family side is pretty average. We've got 3 kids. My wife and I would say, are a joint carers team, and to some extent, Mary, who we provided support for, and her 2 brothers and their families are all sort of involved in this together. So that's my background.
Okay, could you tell us about your experience as a carer with Mary?
So I'm going to actually try and put on the first slide. Bear with me just a second. So I hope you can see the first slide, which is of Mary. This is before she was unwell. So I'm going back now to Mary's teens. She had quite a difficult time at school towards the end of school. We thought she was being bullied. She got quite isolated and then very depressed. And then actually quite suddenly over a couple of months became extremely psychotic. She was visited at home by a psychiatrist, a CAM psychiatrist, who said that he believed that Mary was suffering from schizophrenia. And my wife and I were both health. Anne's a nurse, I'm a GP background, so we were both amazed at this diagnosis. We hadn't considered it. So that was the start of difficulties. And Mary went through 12 months at home with assessments by the CAM service, but nothing seemed to work. Various medicines. We really were struggling at home. Eventually, almost an inevitable crisis happened, and she went into an acute adult ward at the age of 17, and that was shocking. It was inappropriate. So she'd gone from a CAM service where the psychiatrist actually said, if you could hang on till the adult service, they'll be more into psychosis. But Mary was in a service that, although maybe it dealt with psychosis, it certainly didn't deal with young people. So 6 months in this very sort of chaotic and stressful environment. And then Mary moved to the rehab unit, which was actually in the old asylum within my practice area. And in that environment, she just did nothing. She sat on the couch most of the time watching TV. The medicines made her hungry, so she ate all the time. Staff felt sorry for her. They gave her extra helpings of puddings. The only exercise she actually took was to wander around the corridors where elderly men would be smoking cigarettes. Thankfully, Mary never did take up the habit of smoking. But that was the environment in 1995. And at that point, I certainly wasn't a demanding carer. I was very much an overwhelmed and despairing carer, like my wife, and we could see no future for Mary in this environment.
When did you first worry about Mary's physical health? It was in that time?
Well, interestingly, the first psychiatrist that saw Mary, his advice was that I, talking to me as a GP, that my advice was that I should become very expert in side effects of medicines, which was probably quite sound advice at the time. But really, in truth, the real concern was in the asylum. To see Mary doing absolutely, completely sedentary and gaining weight at an enormous trajectory. I mean, she went from 9 stone to 13.5 stone in about 18 months. But also in an environment that was just drab. She lost all her friends. I could sum it up in the sense that, she was drugged up. She was flattened by the medicines. She was definitely fattened by the medicines. And to some extent, she was forgotten. She was forgotten by her friends, not her family, but by her friends. So, and as a GP, I was giving advice to people at that time, prevention of cardiovascular disease was a very prominent part of my job, but this was to a population that were aged 40 and over. And there was Mary, aged 20 years younger, aged 20, experiencing exactly the same risks that I was concerned about in a much older population. So, I mean, I began to realize then that Mary was storing up problems for the future.
Mm-hmm. Yeah. How do you think Mary's mental illness and treatment, antipsychotics, for example, contributed to your concerns?
Well, in the mid-90s, when this was, there was introduction of second-generation drugs was sort of gaining momentum, and the previous, yes, I mean, yeah, thinking back, the big concerns that I was alert to were extrapyramidal side effects. That's what I was concerned about, as a dad in the mid-90s. But actually what I was witnessing was the impact of several different antipsychotic medicines, which were stimulating her appetite. So I think, at that time, the second generation medicines were what Mary was receiving. And the weight gain was just extraordinary. But the research on it wasn't really there at that stage. It was just beginning to be registered as a concern.
Mm-hmm. And as you just said, there was no early physical interventions promotion. No,
in fact, I mean, the staff, the main advice was actually not to do too much. It was good to be very sedentary. It was seen as a good thing to have no stimulation. I mean, the fact that Mary was, on these pictures, Mary's riding a horse, she was walking, she was a very, very active young girl, and all of that stopped. So in a sense, it would have been relatively straightforward to engage Mary in those sorts of things. That's what she wanted to do, but she was very ill. I mean, clearly the psychosis was very, very severe, but she also looked disconnected from all her sort of social environment. So those would have been very important things holistically to work on with Mary at that stage. But you didn't get it. The environment was one where, you just stayed in the asylum, and that was how it was going to be. In fact, we were advised to try and visit a little less. We were seen as that we were a bit too anxious about this. And it was difficult. It was extremely difficult.
You described problems early on. What sort of challenges can Mary and people like her experience in keeping well over the long term?
So we've got like a 25-year perspective now. So all those things that I saw in when Mary was in her late teens and early 20s, what do I see now? Well, what I see now is a young woman in her mid 40s. She has 4 conditions and her brothers don't have any. She takes 11 pills and the brothers don't take any. So she's got a very complex mixture of conditions, and that's in someone who's in mid 40s, not in the 60s. And so she has to navigate health service, lots of different parts of it. She has to take complex mixtures of medicines and treatments that's not always aligned together, and she has to, and also to self-care and to manage her sort of, things like the smoking, things like nutrition and exercise. It's a very, very complex mixture. And Mary now is totally dependent on other people to support her for that. So she's very vulnerable, but she needs extremely precise care. So I guess, that's the challenge that people like Mary face several years on. And I'm left with this irresistible thought that, that what was happening to Mary in her, in the early phase of this illness, now leaves her with very many different challenges as a young woman. Imagine what it would like if she developed diabetes. She hasn't got diabetes. But, the added complexity of a condition like that on her life, it's not so much the threat of dying early, it's just the incredible complexity of trying to deal with those things and to try and alter your whole type of living. So, and I guess the final thought for me is obviously us as carers. I had a significant, well, both Anna and I had significant birthdays in the last few months. So just had 70th birthdays. and we're in reasonably good health. So Mary is very dependent on support and what we can give, what we can do. What's it like when we become a bit more infirm or forgetful or die? You know, so Mary's vulnerability also is tied in with us staying healthy.
Mm-hmm. So it's a big worry for you as a family member. And also, I was thinking about that there is an important health inequality in this matter, comparing to people that have her same age.
Sure, and in some ways, you could Mary's perhaps fortunate. I mean, she does have a very good family around her. Some people don't. Mary does actually live in a very good supported home now, quite close to where we live. So in that sense, Mary's very fortunate. But she has a whole stack of health inequalities to handle. Yeah.
Mm-hmm. Okay, I just want to run up stressing out the importance of early physical health promotion in young people experiencing psychosis. Moving to another question, are you comfortable with the word demanding when describing your role as a caregiver?
Yeah, it's interesting that we chatted about this before when we thought about this presentation. I mean, I guess demanding or reasonably concerned, you know, justifiably concerned, and it's often other people's perception. There were times, I think, probably certainly the first few years, when Mary was in this very sort of drab environment, when we would have been perceived as quite awkward, quite difficult. And you know, as family members, you don't want to upset, there's a real power issue, and you don't want to upset people who are trying to help your daughter for fear that they, you know, that they might take it out on, in terms of a care. There's a quite important person I ought to acknowledge actually in this when we talk about demanding. So I wasn't demanding until this lady became Mary's psychiatrist. So this was sometime after Mary entered the rehab service. A new psychiatrist took over called Fiona McMillan. And Fiona, after only a few days of being on the service in the unit, called Anne and I into her room and said, look, you know, first of all, she explained that she thought Mary was extremely unwell. She had a very severe psychosis. But the second thing that she did was she said, I think you should complain about my service, which is a very incredibly brave thing to do. It's a very honest thing to do. And she understood the turmoil we were going through. And she leveled with us. I mean, she explained that Mary had a bad illness. But she also said, I don't think this service is up to it for all the reasons I've been describing. And we should fight to, you know, and Fiona was prepared to fight to see Mary given a much better service. So we also worked together and spent 2 years complaining, with eventually Mary moving out to a small commissioned service, a rehab service in the community. And you know, and so that's one thing that happened with the complaint. The other thing that happened was Fiona was weighing up the balance of using clozapine or not. It had only just been reintroduced, and you know, shared the decision with us, explained the difficulties, but there wasn't really a lot to lose. Mary had this very, very difficult psychosis. She wasn't really in the real world in lots of ways. So clozapine was started, and within a few weeks, Mary's psychosis began to improve. However, she was still in this really poor environment. So right medicine, wrong place. And she also had to take very big doses of the medicine because she had such a severe psychosis. And it would probably be 2 to 3 years from the onset of illness. So it was, you know, there was a delay for Mary to get onto clozapine, but it undoubtedly was a very effective drug. So I think I became more demanding. I wasn't really demanding. I think I was justifiably angry in some ways. I mean, Fiona, you're a psychologist, of course, Carmen. So you would understand that despair isn't a great psychological response, whereas anger is much more constructive. And Fiona just helped us to channel our mixed emotions and all these things. And we became much more constructive, actually. So we worked incredibly hard to see Mary move away from the asylum. Yeah, so I think we became demanding caregivers for sure at that point. And I think it made a huge difference to Mary.
So the support you received from her, from Fiona, that was a breaking point for you.
It was a complete turning point. It was nothing short of a miracle, really. Partly, I think mainly the honesty. And she had a very, very holistic view. I mean, she is an extremely good psychiatrist. She had a very holistic view. And it showed, you know, she was concerned about all of Mary. You know, she understood who Mary was. And so, yeah, it was good.
Do you think that the culture of organizations back in the time was important to Mary's physical health?
Yeah, that's a really interesting question, actually. So, I mean, and I was experienced as, you know, health professional. Nothing equipped me for the experience of walking onto that old asylum, an 8-bedded dormitory, no curtains, no carpets. It was just unbelievable. And so the culture was really, I mean, the staff weren't bad staff, but they worked in a culture which condoned sedentariness. It condoned people smoking. I mean, a very strong culture of smoking. And they, you know, extra helpings of puddings for someone who's craving food. So that culture was the exact opposite of, I felt, what Mary needed. It was neglect almost, certainly neglect of her physical health. And then by contrast, when she moved to this service in the community, the one that we'd been fighting to establish, that was like a breath of air. Mary had her own room, her own place. She could put her music on loud. Mary never lost the urge to go shopping, or, you know, she took great pride in her appearance. And here was an enabling service. And almost immediately she started to go out. She wanted to go shopping. She went swimming. She went walking. All the things, we got the glimpses of Mary back. So clozapine was great, but it had very little effect on what Mary did in her life until she got into this enabling environment. So that was a positive culture of enablement. And then more recently, she eventually went into another care home, which became not very good. And one of the things, don't let me forget to talk about oral health, but one of the issues that came up was on oral health and the state of Mary's toothbrush, which was appalling in this supported home. And then she eventually moved to a much better home about 5 years ago, and the contrast was fascinating. Again, we had this sort of, a bit like going from the asylum to this rehab service in the community, going from the poor home to the much better home. The oral health thing in current home, she sees a special care dentist twice a year and has fluoride paint, teeth are painted with fluoride. It's a very, and the staff are incredibly proactive in terms of oral health compared to the previous one. And one of the difficulties, I think, is that as a family member, whether you're demanding or not demanding, it's really difficult to know what to expect. And I didn't really, we felt as though we were complaining all the time to this poor care home about things like their approach to oral health. But then when you see a good home providing really excellent care, then it becomes much clearer. And I think that's a real challenge for families, that it's very difficult to know what to expect. And so often, particularly early on, you accept anything, you're grateful for anything. And I'm not sure that's always helpful. Yeah.
And what about clinicians? Do you come across clinicians that listen about your needs? I'm asking you this because sometimes we don't know how to explore or how to listen and risk missing important health issues, as you just said.
Yeah, I think when we see, when you see a good clinician, Mary's been blessed with, Fiona obviously was a good clinician, but so was Mike, the psychiatrist, who had a liaison background and looked after Mary's care for many years. And then more recently, Helen, the learning disability specialist. And what strikes you is that, first of all, the very much like Fiona, very honest. They listen, and they're holistic. They absolutely are holistic in their approach. And I suppose in some ways the difficulty I think with early psychosis is that you sort of don't appreciate that this population are potentially going to have lots and lots of will have lots of physical problems, as certainly we've seen with Mary. By the time you develop, Mary's had her problems now for 20 years or so, and it's very clear that physical problems are important to her. She's on a whole host of different medicines and treatments. So, and so reassuringly, in a sense, Mary sees specialists who are very holistic in their approach. We haven't got any complaints. And so, but I think if we come across clinicians who are not holistic, it shows immediately. We have had, we had one or two difficulties on our way.
Mm-hmm. We have just a few more minutes, and I would like to talk about your role as advocacy, on advocacy. Yeah. Perfect. I have known your work on advocacy, on the importance of an early intervention on mental and physical health. And that's how we met in 2016 during the IFIS meeting held in Milan. I understand that the first IFIS meeting was in 2010. Could you tell us how this collaboration started?
Very briefly, it was a physical health symposium in Amsterdam at the IEPA that the late Helen Lester and myself ran. The first physical health symposium that IEPA had run, a little overdue, I think. And after the meeting, we asked in the meeting, was anyone interested in this topic? We'll be at that table over there and we'll have a cup of tea. And 6 people came, one of whom was Jackie Curtis. And Jackie was waving an algorithm for cardiometabolic risk that she and Hannah and Kathy had developed over a weekend as a training tool. And Helen Lester and my eyes lit up when we saw this. And so we were duly pinched it from Jackie and went back to England with it. But that meeting, that sort of cup of tea, is just the classic thing, isn't it, at a conference? Sadly not at a virtual conference as easily, but we were sat there chatting and like-minded in our views. And Jackie explained that she'd been working on this issue for years, and I explained, and Helen explained, that we'd been worried about this issue for years. And so we got together. And when I went back home to England, I was part of a national clinical audit where the physical healthcare was clearly a big issue. And the director of the program said, David, your job is to nick this resource from the Australians. So Helen, myself, and Jackie had a time of transferring. And the Aussies took a weekend to develop this resource. We took 18 months to prove that everything was correct in it, by every committee you can imagine. And out of that collaboration then has come a whole host of different things, some of which was that we collaborated then to create a consensus statement, which became known as Healthy Active Lives, the HEAL statement. And that was launched in the Tokyo IEPA, I think, 2014, I'm getting it wrong. And then various other resources. But again, the whole issue has been about early. So we've called some of these resources right from the start. So it's been a joyful collaboration. We're still working together. Currently, we're working on an all health consensus statement. So it's amazing, isn't it? The power really of alliances. And all of these resources have the same approach of involving service users, family members, clinicians. So yeah, that's how we got to meet you, Carmen.
Yeah, that's right. So now coming back to your role as a caregiver, may I ask you, how is Mary doing now?
I think I've got one more photo. So this is Mary's 40th birthday, which is 5 years ago now. And I guess the importance of this set of pictures for me is that, it shows this is someone who was almost written off 20 years ago, 20 years before this photograph. she's very engaged with the family here. So that, you know, and her nephews and nieces. You know, this is a whole family. She lives locally, which is very important. She has very high, precise care from the care home she's in is superb, and we don't worry about her quite the same. So Mary's care is excellent. We can just, you know, I don't have to be a demanding dad all the time, we've got much greater confidence for the future. But nevertheless, you know, as I said earlier, Mary has many medical conditions to deal with, lots of different treatments. So there are challenges for her, but you can see that her quality of life is clearly good. And it's good today. Even with COVID, it's, you know, the home have been superb through COVID. Absolutely brilliant.
That's good to know. Thank you so much for sharing your experience. Hopefully this conversation will inspire clinicians to incorporate caregivers' perspectives as an important tool to improve interventions and also connect everyone involved in early intervention services with the needs of service users. Thank you very much, David.
It's a pleasure. Thanks, Carmen.
See you soon.
Bye-bye.
Thanks, David. I would like to remind the audience that we have uploaded all our presentation abstracts, and also David had uploaded the Healthy Active Life International Consensus Statement. Feel free to download all the resources. I have also wrote some websites on the chat that could be of your interest. I have a question from the audience that I would like to read. This is a question for you, Sarah and Bryan, and I'm just gonna read it. 1 second. This is from Kendall Baker. It says, I work in a clinical high risk and first episode program in Oregon, and I have found it difficult to engage families even when we do offer the family supports and services. Do you have any suggestions on how to engage families who do not participate when services are offered? I am wondering if you notice any differences in rural versus urban settings in rates of family utilization of available resources.
Those are both two really important questions. I will speak to the first, and then I think I'll enlist Bryan Stiles to speak to the second question about geographic disparities. I think first of all, you know, we want to understand what are some of the major impediments to family accessing services. I think we have this notion that if we build it, they will come, and that's not at all the experience in clinical settings. And so we do see barriers at the family level, but we also see barriers at the client level, the provider level, and from the systems perspective as well. And so I just want to address those because I think we need to take a holistic view of the problem before we can hone in on one component. So at the systems level, I would say that family engagement, at least in the US, if it's a fee-for-service model, may not be a reimbursable service. And so that's going to automatically down prioritize it for the system. Staff may be unwilling or unable to provide interventions during times that family members can accommodate, or the decision makers at the organizational level may not really be attuned to the benefits of family intervention. And I would say actually that barrier we see across all of those levels, that the system, the provider, the individual client, and the family aren't actually educated oftentimes about why these interventions are so important to the recovery process in terms of both the psychiatric health of the individual, the physical health of the individual, in terms of their substance use, costs, all sorts of outcomes. At the provider level, we see just inadequate access to training in different kinds of family interventions. I think sometimes, again, not fully understanding the benefits to their clients, there may not be that motivation to administer, or it may not be within their role. I think we are less likely to be seeing that in early intervention care teams because we take a multidisciplinary approach. But sometimes, especially right now with our workforce issues, it is all hands on deck, and family interventions are one of the first things to go if they're there in the first place. And then I think service users often are actually reporting, more often than not, a desire for some family engagement. They may not want them involved in their mental health care, but they may want psychoeducation. They may say, yes, that's fine if you offer my family skills training. And so working with the service user around what does family engagement look like to you in a way that is comfortable to you and acceptable to you. And then at the family level, which is where our question asker started, is we do see these high rates of refusal. We do see disengagement and quote unquote non-adherence, right? They're not actually adhering to the family intervention treatment course. And that has been longstanding. And actually, I think it was one of David's colleagues, Joe Smith and Birchwood, who looked at this in the 1990s that said these are, really high rates of premature disengagement from the family. And so I really recommend that when we understand all of the components of the problem, then we can take a more productive problem-solving approach. For the families, in terms of the clinicians targeting family engagement, I would say there's a few things that we can do that actually start with the service user, which is informed consent in a way that talks about risks and benefits by first getting their perception of risks and benefits of involving the family. And related to that, to actually assess what are their thoughts and feelings about involving family. And then on the family side, if you're able to connect with the caregivers, just ascertaining what are their thoughts and feelings about engaging in care. And the reason that I would recommend doing that is because you can start to develop a little formulation about what might be going on, what might be contributing to poor engagement or follow-up. And so then we can we're not really spaghetti throwing in terms of our problem solving approach. We can be far more directed. We can test that treat it as a hypothesis, test that hypothesis with a problem solving strategy that matches onto the problem identified, and then see how we're doing. Because oftentimes I do think we tend to jump in with some practical solutions. And then I think the other kind of piece of that is just delineating what are the boundaries of family involvement in care, and using the shared decision-making model so that the family and the client and the clinical team all have equal say, or all have say in the locus of control of the treatment, and again, how family are involved. I think oftentimes we don't think about psychoeducation as an engagement strategy. But when we provide recovery-oriented psychoeducation, we can really provide a lot of relief. We can destigmatize psychosis for family members, and we can actually foster this, maybe empower them to talk to their loved one and even normalize some of the psychotic experiences that their loved one is experiencing, which kind of gives them a way of starting to repair that relationship and also feel empowered, if they're doing something helpful and productive. I think making sure that we are addressing the family stress and talking about the fact that this is something that's intended for them and to help them be a more effective caregiver by targeting their stress levels. And then finally, I would say in cognitive behavioral therapy for psychosis, oftentimes for clients that are having difficulty engaging in the treatment, we'll use brief behavioral strategies to essentially promote hope and optimism in the treatment. Hey, that grounding strategy actually helped with my voices. Maybe this person can actually help. Well, we can do the same thing with families. We can teach them these quick behavioral skills, give them some hope, and maybe that provides a foot in the door. With regard to the geographic disparities question. So our sample, we didn't have a sufficient sample or sufficient representation from family members in rural areas to do a comparative analysis. Anecdotally, I will say that caregivers are less likely to be involved in care in rural settings, but we actually have empirical evidence of that as well, at least for coordinated specialty care broadly. Bryan, do you want to speak to that?
Yeah, just to follow up, although we don't know about kind of the rate of service utilization by families who are kind of in a more rural area versus urban, we do know from one of our colleagues at Washington State University, Duni Olewoye, that she conducted a geographic study of service accessibility and I believe utilization as well, in terms of kind of factoring in rurality versus kind of urbanicity. And, she found that individuals in Washington State from rural neighborhoods in sort of the second lowest tier of neighborhood deprivation, so neighborhood deprivation being this sort of level of socioeconomic disadvantage in terms of like poverty, housing, employment, education, have the lowest accessibility to coordinated specialty care programs in the state. And that tracks, right, with other research that we know about kind of low socioeconomic neighborhoods, rural neighborhoods have limited accessibility to mental health services, speaking in terms of the United States. But to just kind of follow with what Sarah was saying, I think another important layer to consider here is, as we're kind of considering engagement with families broadly, it makes me think about the importance of considering how race and ethnicity and neighborhood or geographic location interact and factor into sort of broader disparities with family engagement or family utilization of CSE services. I mean, we know, again, from Duni, who's a bit of a superstar, that, Black families from the RAISE ETP study had lower family psychoeducation utilization. So, we might want to consider how individual race or likely, the experience of negative experiences with the mental health system, disproportionately among Black families relative to other racial groups, or the individual experience of race-related stress interact, with socioeconomic disadvantaged backgrounds to kind of in a multiplicative fashion to bring about these low rates of family utilization of resources.
Thank you, Sarah and Bryan. We have another question, and this is for you, David. This is from Paul French. And he says, incredible to see all these incredible resources around physical health. Any up and coming additional ones you have in mind, David? You're on mute.
Okay, great. Great, thanks, Paul. Nice to hear from you. I mentioned just at the very end of our conversation, Carmen, that there was some right from the start resources that we've most recently developed. One on keeping the body in mind, one that Jackie developed on why quit on smoking, and then one that we most recently did on oral health. These are very simple tools. The main idea behind this is to raise expectations from people and their families to ask for more. So that's sort of back to this sort of demanding sort of idea. But the other thing we're doing at the moment, and I think it's interesting, it picks up onto this sort of health inequalities and disadvantage theme, which I mean, Bryan's just touched on to some extent as well, because whatever physical health issues we see for people like Mary, they are so much worse if you come from a racial disadvantage, socioeconomic disadvantage. But at the moment, we're looking at oral health, and we're hoping to create a consensus statement, really because there's such a lack of initiative in terms of research and interest in the topic. So we're at the point where we think to draw together a consensus from a group of people, experts in the field, service users and family members, to try to lever some interest and momentum to draw in research, to draw in clinical change. But people like Mary have got 2 or 3 times the risk of losing all their teeth. They have 5 more teeth with fillings in than someone who doesn't have severe mental illness. It's a huge health inequality, and therefore an opportunity to do the sort of things that we've seen happen to Mary in this very good home most recently. So there really are opportunities to do something about this. But I will be coming round to people asking for connections and hopefully interest in this sense of an oral health consensus, which we're anticipating will come in the new year. So that's one thing. The other thing we will be doing is reviewing the Leicester resource and the algorithm that Jackie's initiated. It's 2014 since we updated it, and there are some small changes in how vascular disease is managed in the UK for sure. So we will be updating that, and hopefully that will give it a little bit more of a boost as well. Yeah, so still more to do, and there's plenty more I think that needs doing as well. I mean, issues like sexual health, hugely important for this population, and bone health. I could go on, but I'll shut up.
Thank you, David. You can find all those resources in IEPA's website, and some of them are translated in different languages. So, and if you can't find your language, please contact us, Jackie or David, and we will ask you if you can translate it for us.
As long as you help me translate it, yes.
We don't have any other questions, so if you want to add a comment or say something else, you're free to do so. Otherwise, I want to thank you all. Looking forward to continue working together. Since we were able to organize this symposium, I think that we are ready to organize something else, like an intervention, or maybe collaborate to each centers. I was thinking about family peer trainers, or how to do some crossing some of the works that we have mentioned.
It would be very interesting to connect with some of your families over the physical health issues. I mean, that would be a very interesting, I'd love to meet some of your families. I'm very inspired by hearing you talk, Carmen. I wouldn't have been anything as demanding if I'd been in your service.
Thank you, David. It's been a really inspiring interview with you, and also I want to thank Sarah and Bryan. We didn't met before, and I'm really grateful that you came you accept the opportunity to be with us today and share with us your important results about working on families, and how this new concept of training families, it just, I think that's very important, something that we can start doing and thinking more. So thank you very much for your time and your excellent presentations. We are now going to a closing. To watch the closing, please click on the Watch Live button located on the top menu bar and select room 1. For any sessions you miss, recordings will be available on demand within 24 to 48 hours at the conclusion of the live events. And that's it. Thank you everyone for joining. See you next time.